And we'll go ahead. There you go, got that. And I think we can go ahead and start, and I will give everyone a welcome. Good afternoon, everyone. I'm Gary Harbison. I'm the Executive Director of the Missouri Coalition for Oral Health. MCOH is a nonprofit dedicated to improving Missouri oral health. We are a statewide network of oral health advocates. We raise awareness, engage with community members, advocate for policy change and system improvements, and work together to increase health equity. Please follow us on Facebook, Twitter, and LinkedIn, and through our website. So welcome to the first of 3 pre-conference webinars for the 2022 Missouri Oral Health Policy Conference. You can find more information on the upcoming conference on our website. Just as an aside, I will tell you we have done pre-conference sessions in person before, running concurrently, and we've gotten a lot of feedback from the surveys that people really wanted to go to all of the sessions we had, and so one reason then that we decided to do these as webinars is to make it so that people could attend all 3 if they wanted to. There's more on the website about the other 2 webinars as well. And thank you all for being here. Please feel free, as Ashley mentioned a minute ago, to type your questions through chat in Zoom or raise your hand. We're going to be monitoring and trying to respond to those. You have been muted because of the number of participants, and we are gradually pulling people over where if you would like to have your camera on, you can. That's a nice thing to do for a presenter, because otherwise they have no idea if you're sleeping or writing email, reading the newspaper, whatever, out shoveling the driveway. So think about that. I wanted to give a special thanks to the Office of Dental Health with the Missouri Department of Health and Senior Services for sponsoring this and the other 2 pre-conference webinars. And a special thanks to the Missouri Primary Care Association. And hey, somebody's using the camera, way to go. And and I wanted to also especially thank Karen Dent for working with us on the CEs for attendees. And as you all heard earlier, another camera, good deal. As you all heard earlier, we are recording the session, and we'll make the recording available later, probably through our website. However, we won't be offering CE for the recordings. There will be a CE code at the end of the presentation, and we'll probably put that in chat and verbally mention it. There will also be a survey link that we'll put in chat, and then we'll send that out by email to all of the participants. Let's see. Well, with that, I think that takes care of the kind of details. But with that, I want to introduce Dr. William Moss and give you a little bit of background on him. Dr. Moss is a dental public health consultant and clinical professor at the University of Maryland School of Dentistry. He has served as an advisor to the dental campaign of the Pew Charitable Trusts. He has served in the Indian Health Service, the Agency for Healthcare Research and Quality, and the Centers for Disease Control and Prevention, where he directed the Oral Health Division for 10 years. In each agency, he identified, developed, and disseminated science-based policy relevant information needed by patients, clinicians, health plans, purchasers, and policymakers to make better oral health care decisions. From 1997 to 2001, Dr. Moss served as the Chief Dental Officer of the U.S. Public Health Service, as an Assistant Surgeon General, and was a member of the project team that prepared the first ever Surgeon General's report on oral health in America. Now that's a part of history there that's very, very important. Dr. Moss has a particular interest in the delivery of preventive services to individuals in underserved communities. Since 2016, he has served on faculty of the Sealant Improvement Collaboratives of the National Network of Oral Health Access. Dr. Moss is board certified in dental public health. He earned his degree from the University of Michigan and public health degrees from Harvard University. So please join me in welcoming Dr. Moss.
I'm going to try to share my screen now. Let's,
Should be a screen share button. There you go.
and now I need to pop it into presentation mode.
Yeah.
Which I'm not seeing.
It's usually from the bottom. Nice photo. There you go.
Okay, this is okay. This is interesting. You have to tell me what you're seeing. Are you seeing like a full slide, or are you seeing all the notes and stuff like that?
No notes, just the slide.
Oh, okay. Let's try another one. Gotta make sure I'm clicking on the right. Did the slide change? No. So you're still seeing the cover slide now, right?
Yes.
I have two monitors here. Maybe the thing I need to do is go to my settings and turn off the other monitors so that I don't even have a choice about what it goes to. So let's try that. Now it just told me it just disconnected the share screen, but let's try it again. All right, screen back again.
It is, and there are no notes. It's just the slide.
But now, so I just tried to advance, and it didn't advance. So what's the next thing we need to do here?
You want to advance it to the next slide?
Yeah.
Just try your.
Oh, okay, I guess I have to rotate my mouse instead of. Okay. All right. I think we're cooking with gas here now. So I've no disclosures. I'm not trying to sell anything. I've got no connection to any of the products here. Now, you're seeing a what I'll cover slide?
Yes.
Yeah. Okay. So as it turns out, the very last live presentation I made was March 2020 to the pre-conference session at your annual Oral Health Conference. Since then, I've made a lot of presentations, with webinars, but so it's really kind of so I remember that. I remember that meeting very much, and while we had heard about COVID, there was some awareness of it there. People were starting to do the elbow bumps and the fist bumps and stuff like that. It was really quite a dramatic change just 2 weeks after that. So, however inspired people might have been, leaving the conference with all the ideas they had for change, I think we were swept up into a very challenging situation, and I'm not sure how many of us were able to really implement things that we might have learned at the conference. Dentistry as an industry has recovered, say they claim up to like 90%. I don't think that's necessarily true of community health centers. I think they took slower to recover. And even the safety net of private practices treating patients enrolled in Medicaid has not recovered, at least evenly across the country. If you're involved with school programs, you can't even see light at the end of the tunnel, total disruption. So, but the one thing that might have occurred in this last 2 years is more use of silver diamine fluoride and glass ionomer filling and sealant material. Those were things we discussed last time, and because of their ability to use those in a non-aerosol situation, many of you actually may have had more use of those products since then. So, so in that context here, I hope that the ideas that insights we gain from discussing these issues again today are something you can look forward to implementing in practice as we get close back to a new normal. So again, kind of thinking about 2 years ago, I was intrigued that a few months before that early March Missouri meeting, the American Dental Association had a workshop, and the title of it was Dentistry for the Modern Age. But it was actually a workshop that they'd held every year for several years, and previous to this, they called it evidence-based dentistry. And the bottom line for this was that we would become better dentists by practicing scientifically informed treatment. You know, the notion that when you graduate from dental school or dental hygiene school, you try to practice exactly the way you're taught, you know, that might be, you know, appropriate care for the first day or the first year. But as new scientific information is learned, we need to be prepared to if they, you know, to figure out how those inform the care that we should be providing for patients. This terminology that the ADA used, dentistry for the modern age, though, kind of get a kick out of it, because in dentistry, I guess modern is relative rather. So here's a cover page from an article almost 30 years ago. And notice the very terse abstract. Just a few sentences, but basically the punchline was that treating the disease, not the symptoms, is what this author, Dr. Max Anderson, thought would be the change in managing modern management of dental caries. So when we think about disease versus symptoms, what did he mean by that? Well, what I'm showing here is a picture of occlusals of molars, and this is something we're seeing with our eyes, so we would call this the sign. We're seeing these signs. Symptoms I think of as something a patient perceives. So what does the patient perceive? Well, certainly on that tooth on the right, the patient at the very least, you know, can feel that pull with their tongue. Maybe food gets packed in there and is annoying to them. Perhaps even they're feeling some sensitivity or even some spontaneous pain from that tooth. They may also be aware of the tooth next to it, but those other teeth, the patient probably has no symptoms at all. Now, while that was a picture of occlusal surfaces, I think if we you know, think more about what our understanding of the disease, while it presents differently, that same disease, dental caries, can occur on smooth surfaces that are accessible to the eye, and on other smooth proximal surfaces that are not visible to the eye but can be detected with radiographs. And I think now we understand that with the exception of the sound teeth on the far left, all of these teeth have disease, even if they don't have symptoms. But which of these need to be treated? Now, if by treatment we mean drilling and filling, then I think we probably have wide agreement that we should treat the tooth on the far right, probably even a lot of agreement that we should treat the next tooth. And I'm sure you will find dentists, perhaps among you, that would treat with drilling and filling the teeth in the middle, or maybe even all the way to the left, the second to the left tooth, as soon as they see some stain, with the justification that the tooth is at high risk of caries and that they can do a nice small filling here and kind of solve this patient's problem. They won't have to worry about getting tooth decay in that tooth. So all of these teeth need to be treated, but I would disagree. And in fact, it's the old paradigm to think that the drill and the fill is the way we would treat them. In this old paradigm that the traditional philosophy that Dr. Anderson wrote about in 1993, we were very much focused on plaque. In fact, we thought it was modern to talk about plaque. And people had phase contrast microscopes where they could take a scraped plaque and show it to patients, so patients understood that these were bacteria there. But the real focus was on cleaning that plaque off the teeth. And the idea was that you had to meticulously remove all that plaque, and you had to do that continuously. We brought patients back to see if any new lesions developed. And if the lesions did develop, then that was certainly a sign it was the patient's fault. They hadn't removed all the plaque off the tooth. But we also knew by then that surgically removing that diseased tissue and putting an inert filling in there really didn't address the disease. which is dental caries. There, and in spite of what Dr. Anderson showed us in 1993 and the evidence that that the scientists have provided since then, it's been very difficult to change practice. Most of the profession is still focused on repairing the consequences of disease. And one of the reasons for that is our entire reimbursement and financing system supports that approach. The public perceive us that way. So even if your concept of disease and treatment options is changing, you're practicing dentistry in a system that's really was designed for that traditional approach. Now, some of you were at the session 2 years ago. You might know what these numbers reflect. In fact, if you're a person with diabetes or know somebody with diabetes or another chronic condition, you may know what these numbers reflect as well. 2 hours is the hours a person with a chronic disease typically receives over the course of the year, the time they're in the clinic with their doctor or their dentist. Over 8,000 are the remaining hours in the year. So it's really important that what we do in those 2 hours we have with the patient, what we do for them and what we tell them has to be the very best use of our time, very best advice we can give them. We do not have enough time with them to waste on ineffective clinical services or suggesting that they perform ineffective self-care behaviors. So this calls for changing the paradigm with which we review evidence. Gary mentioned the year 2000 Surgeon General's report, and it was about that time that people began talking to mothers about the fact that they were transmitting cariogenic bacteria to their children. And we became very aware that infants and toddlers received the cariogenic bacteria from their parents, from their siblings, from their playmates. And we began to talk about caries as an infectious disease, but it's really not an infectious disease as we classically think about that. Really, all the action in caries, it occurs in that fluid that's right at the tooth surface. It's certainly absolutely affected by the bacteria that are there, but the real action is that fluid right at the interface of the plaque and the tooth. Caries is no doubt a complex multifactorial disease, but it's a chronic disease, and that's the way we need to approach it. Again, year 2000, really a time when we really began to change how we understood dental caries. This was a cover story in the Journal of the American Dental Association, JADA. People began to use this terminology, use this concept of a balance a balance of protective factors and pathological factors. And when there was too many pathological factors, the balance tipped towards having caries. When there were more protective factors, then the balance tipped towards no caries. And that article also kind of showed us in a diagram of what was happening at the molecular level. Again, the action is right at that tooth surface, where rather than thinking of tooth decay as a progressive disease, we began to understand it more as a cycle of demineralization and remineralization, depending on the saturation in the oral fluids immediately next to the tooth. And in the presence of fluoride, the dynamics of that change in that as the tooth remineralizes, fluorapatite is formed, which is more resistant to the acid being generated by the cariogenic bacteria in the plaque. So now we really understand that in the early stages of caries, it can be prevented, reversed, or arrested through a combination of eliminating those factors that are causing the disease, they're causing the demineralization, and enhancing those that shift the tooth more towards remineralization. In fact, while we may talk with our patients using the term prevention, we're going to prevent caries, I think we need to think more in terms of control. We need to control the caries to prevent the permanent loss of tooth tissue that will then necessitate restoration. I'm overlaying those pictures that we saw before with more of a schematic where we kind of think about this chronic condition. This would be actually some of the same phrases that healthcare professionals would use to talk about other chronic diseases. There's a preclinical phase before anybody's aware of anything's happening. Disease actually may be initiated before anybody's aware of it. And then at some point in time, there's a diagnosis, kind of two categories of that: an early diagnosis where certain treatment options are available, and then a late diagnosis where perhaps we don't have the same treatment options, and carry it all the way to the end without treatment, depending on whether we're talking about a tooth or a person. We either have the loss of a tooth or the death of the individual. The old paradigm was we waited until we had a cavity and saw a cavity and we treated it. And what we know about that is if we use this approach, we treat that cavity and put a filling in there. And since no filling lasts forever, we continue to repeat that. Every time the filling fails, we put in a new filling. And typically that's a larger filling, removing more tooth tissue where the tooth has been, badly damaged and is starting to break down. So we keep repeating this particular treatment over and over again. The new paradigm is to do something at those earlier stages. Do something, and if we repeat that, do it over and over again, and keep the disease from progressing to that cavity state. Our opportunity to find out whether an alternative to surgical approach occurs started about 15 years ago in a collaborative that was led by Dr. Man-Wei Ng, a pediatrician at the Boston Children's Hospital. Early childhood caries, as you know, is a disease. We start, child's born with intact teeth, and then over the course of just a couple, 3 years, the teeth can become badly damaged and destroyed by dental caries. But that also means that this is a great place to test our interventions, because if we have a successful intervention, we'll be able to see the results over a relatively short period of time. And that has been the case with this shifting from a surgical approach to chronic disease management. And the findings from that collaborative were that the outcomes were that kids had fewer cavities, that fewer kids reported pain, and fewer children were referred to the operating room. So over the course of the last dozen or so years, they've refined how both the information they collect from patients and the treatments that they provide. But the basis of it is to do a caries risk assessment. The example here is from the American Academy of Pediatric Dentistry, and it's for 0 to 5-year-olds. They have a different one for 6 and older kids. And there's yet another one to be used by non-dentists, asking us somewhat different questions. But the whole idea is to try to categorize what risk of caries there is, which has implications both for the clinical services and what we call the self-management goals. Self-management goals are the things that we send the patient, or in the case of young children, their parents, behaviors that they're going to need to change in order to change the progression of caries. So that's, again, one part of it is using the caries risk assessment and the answers to questions to decide what to focus on for self-management goals. But then there's also, now with increased experience, how that affects our clinical care, the recall intervals, the specific services provided. This initiative, I think, interestingly, it's interesting to note, started before SDF was available in the United States. So they were successful even before they had SDF. And now over the years, as they've continued to refine these protocols, it's evolved to include SDF. But SDF is, we might have considered it quite a game changer, but it's really, its use is put in the context of these other things that are part of a much more comprehensive chronic disease model of care. My colleagues in the pediatric department at the University of Maryland have determined that while that protocol was developed by pediatric dentists, for pediatric dentists, that many of the services can be provided by general dentists. So this, they wrote an article that appeared in the journal General Dentistry, which is the journal of the Academy of General Dentistry. And I call your attention to this active surveillance loop. The University of Maryland likes to use this term active surveillance, and it doesn't mean watch. Watch, it's been told to me, watch stands for wait and then cavities happen. This is very different than that. This is very active in terms of monitoring and recall and using, as you can read here, fluoride varnish, silver diamine fluoride, interim therapeutic restorations, and a particular recall interval. And I would go to say that while, again, this is focused on general dentists, most of those services in this blue circle can be provided by dental hygienists, and they don't need to be provided in a dental clinic. Most of those services can actually be provided in other settings that are perhaps more convenient for parents to bring their children to. So if we were going to have the whole presentation on the modern management of caries, we would need to cover the whole spectrum of issues here. But today, really, we're going to focus on what's in red here, the interventional strategies we have for preventing, arresting, and possibly reversing the caries process. So let's start with this thinking about what we need to do for this high-risk patient. This is the level of evidence. This is at increasing levels of evidence for the stuff at the top. And I'd like you to take a look at this and think about how these treatments compare with the things you prioritize in your clinic or in your program. And one of the things you may notice that's prioritized in your clinic but isn't here is prophies. Dental prophylaxis was not on the list of caries preventive treatments. Why not? Well, it's because there's no claim that by the Academy of Pediatric Dentistry that dental prophylaxis has any effect on caries prevention. I'm not saying you shouldn't do it, just don't do it as your way of preventing caries. Yet, in my experience with the community health centers that participated in the NOAA collaborative, was that many clinics faithfully provide prophies at the recall visit, and at the first visit, and at all the recall visits. And they defer services that would be much more effective in actually controlling caries. And all too often, those appointments that are made after that first visit are not kept. So they use the time of that first visit to provide services that aren't going to affect caries and defer the ones that could prevent caries. Another thing you'll notice that's kind of down the list here is diet modification. And it's not because diet isn't important. It's further down the list because we don't have good evidence that we're very good at changing that diet. There's no question that sugar contributes to caries, both in terms of quantity and frequency. Some have suggested that it's so hard to change diets that our emphasis should be on frequency rather than asking people to keep track of how many grams of sugar they're eating or their child is eating or something like that. But the other thing about focusing on frequency is it's consistent with our understanding of the caries process. I'm sure you're all aware of these kinds of graphs where we are plotting over time what happens every time food or sugar sweetened beverages are ingested. The cariogenic bacteria generate acid. The acid changes the pH level of the fluid by the tooth. And when it drops below what's called the critical pH level, demineralization occurs. So it makes sense that if you can limit the number of times that the pH level drops below that critical threshold, you're going to reduce the amount of tooth decay. So again, I think you can see see my mouse here. So when this is a Stephan's curve, and during the time when the pH is below the critical pH, over this amount of time, minerals are lost. So the total amount of minerals lost is this shaded area. If we can lower the critical pH, and fluoride does that, fluoride makes replaces hydroxyapatite with fluorapatite at the surface. and so the tooth is more resistant. If we can lower this line, then you can imagine that the total shaded area is going to be less. So that's how, by lowering this line with fluoride, even though the demineralization and remineralization are occurring, we're reducing the total amount of minerals that are lost. And as we talked before, the fewer times a day that this occurs, the less mineral is going to be lost. Think about what we now understand as a white spot lesion. Tooth erupts. We know that they are not completely, the surface is not completely mineralized when the tooth erupts. So there's a little bit of an increase of what was called the post-eruptive maturation. But during the time that let's say the plaque is on that surface by the cervical gingiva, we're going to see some mineral loss. And in the presence of fluoride, and then let's imagine we put a high dose of fluoride varnish on the tooth and then continue with the patients using fluoride toothpaste more frequently, or perhaps fluoride mouth rinse, with the mineral, it stops being lost. And at that point, this is what we call an arrested lesion. It still may be detectable. You may still see it as a white spot, or perhaps it'll even change color, or perhaps we caught it early enough that we change enough of the mineral content at the surface that the tooth once again becomes kind of translucent instead of opaque, and we no longer see that white spot. And that's what we're trying to do when we see a white spot lesion. We put fluoride varnish on it, and have the patient or the caregiver make sure that they're putting fluoride toothpaste in that mouth twice a day. But if we don't intercept it that way, that's the continued demineralization that will result in cavity over time. One final note about using fluoride as a anti-caries agent. This study was performed on adults, but I think the same is true for children. One-time delivery of the anti-caries agent was no better than no care. So I'm thinking about those school programs often, or those programs where we see the child, we put fluoride varnish on the teeth. Do know that the only reason to believe that fluoride varnish is going to be effective is if you can bring the patient back for another application of fluoride varnish. And exactly what interval that is going to vary. Obviously, the effectiveness is going to vary somewhat, but I think the main point is to not think that somehow or another, just by providing that one dose of fluoride varnish, that you've somehow changed that patient's caries trajectory. But repeated applications, in fact, can reduce tooth decay even in high-risk patients. Returning kind of to this visual of the occlusal surfaces of the teeth again, we have different ways that we can call those, but for sure we distinguish non-cavitated caries from cavitated caries, and we start thinking of terms like remineralize and arrest. And while some people will restore teeth even at areas that could be arrested, the idea is here to keep moving more with more attention to the non-restorative alternatives, and we'll talk about that more. This is new information is coming along, abundance of information with little guidance. So what it is now, over 3 years ago, the American Dental Association, through its Council on Scientific Affairs, promised us that they would start sorting out the scientific information and giving us guidelines. And they had this plan to roll out one guideline a year, starting with the one we'll talk about in a minute from 2018. And if you see what their plan was, they're going to roll out one per year. They're going to talk about, the first one was non-invasive treatments. The next one was going to be effective strategy to keep caries free, kind of primary prevention. Then they were going to talk about recommendations for restorative treatment, and then detection and diagnosis. I have no inside information about why the ADA hasn't been able to generate any more guidelines. I have no information at all, but it is something to look forward to. There's no doubt that there's not a need for it and a acknowledgement of the need for it, and we will look forward. But I think the thing we need to do is we've had these existing guidelines for 3 years now, And so let's put our effort into making sure we implement everything that they told us about before. So the gist of that, those guidelines from October of 2018 was that there are effective approaches to arrest and reverse curious lesions that are non-restorative. And they encouraged clinicians to prioritize use of these based on effectiveness, safety, and feasibility. When I first read the feasibility, I thought, well, it sounds like a catch-all, like, any excuse you have for not being able to do that is I guess what you could say was a feasibility thing. But I think the greatest challenge in terms of feasibility is the fact that, as I mentioned earlier, our dental plans and the reimbursement policies aren't designed to encourage that. Now, I think recognizing that for some patients, this is going to seem like really crazy for their dentist to say, yeah, you've got some early tooth decay and we're not going to drill a hole in that tooth. At the same issue, the ADA developed a one-pager for the patient. There's a section of most issues of the Journal of the American Dental Association for the patient, in terms of patients understand. And they recognize this was going to be a problem for the patients. So they wanted to make sure that the patient didn't think the dentist was doing some, goofy, performing an experiment on them, that this was well accepted guidance. But imagine the challenge for the dentist to say, we have early decay here, and your dental plan will pay me to drill a hole in this tooth and put a filling in it, no questions asked. But I don't think that that's the best thing for you. I think there's some other treatments we should use, but unfortunately, you'll have to pay for that out of pocket. Your dental plan won't. Some of you have probably faced that in your clinic. This is an example of a barrier to us implementing this approach to care. But I think that barrier will only be overcome by us implementing the system of care and putting pressure on the dental plans to be responsive to that. This is one of the diagrams that comes from that article. I really encourage people to read the full article because that provides the nuances, not only of the overall strategy, but if there's some things that you would have expected to be on this list that aren't, it explains why the evidence doesn't support that. The things I will point out to you here, though, are Sealants is the service that is recommended for non-cavitated occlusal carious lesions. Again, not just on sound teeth, but it is a recommended treatment for non-cavitated, meaning we know there's decay there, it just isn't a hole yet. Sealants are recommended. But also, and it may surprise you because this is a guidance for permanent teeth, SDF is also provided as a recommendation for cavitated surfaces, actually on all surfaces of the tooth. There is a different diagram for primary teeth in this particular article, but they're really pretty similar. And one of the things that is in common for all of the preventive strategies is this recommendation at the bottom that lesions should be monitored periodically throughout the course of treatment. Remember, we're dealing with this as a chronic disease, which means it's a continual monitoring. This is something we're going to be following every time the patient comes back. Wouldn't it be nice if there was some gizmo that we could buy for $1,000 and touch it to the tooth, and the gizmo would tell us whether there was any caries activity? Unfortunately, there isn't. There's gizmos out there, but there aren't any that are valid biological or clinical tools to assess caries activity. And there's no single variable that predicts whether the lesion is active or rested. So you need to use some judgment. And I've used the term, or this reference uses the term clinicians, and I use that term as well because this is not something exclusive to dentists. Dentists may be the only ones, for whatever reason, that are allowed to say they've made a diagnosis. But assessment is something that both hygienists and dentists should do, and I think a dental team will want all of the members understand how to assess carious lesions to determine whether they're active or inactive. And that's both how they look and how they feel, and to be wise enough to look in those areas that have potential for plaque accumulation. And there's guidance for that. It may seem surprising that brown is actually a sign of inactivity, but in fact it can be. And if it's not an area that's of aesthetic concern for patients, that can be a sign that the treatment that was provided before is arrested. So again, there's both visual and tactile ways to monitor. Oh, and the other thing I wanted to say about this, so high-risk patients can have a lot of places in the mouth where we have these early lesions. And it really would be too much to monitor all of those. So pick 2 of them that are easily visualized or easily accessed, and monitor those, because in very likelihood, whatever is occurring either successfully or unsuccessfully for those 2 that you can see is probably happening in the other ones as well. So make this an important part of your practice, but make it manageable. Finally, I want to say about home delivery of fluoride. We are finally, I think, now this is what, a dozen years ago, 10 years ago, finally have kind of consistent recommendations on the use of fluoride toothpaste. Before that, it's like, at what age should you not use toothpaste? Should you use toothpaste? How much should you use? We now have recommendations that they're kind of widely shared across the dental profession, and with pediatricians and family medicine docs that are overseeing the oral health of infants and toddlers. So we're at least consistent about that. Now, it takes a long time for these even when we're consistent, it takes a long time for those to trickle down into the community, because parents aren't the only caregivers, grandparents, even older siblings in some cases. And so not all of them have had the same access to this message as others. One of the messages that a lot of emphasis has gone into is this message of brush twice a day for 2 minutes. And I think it's important for us to know that twice a day brushing with fluoride toothpaste is really important. The 2-minute brushing time was based on evidence of superior plaque removal. There's no evidence that brushing for a full 2 minutes has any effect on either gingivitis or caries. So really focus on the brushing twice a day with fluoride toothpaste. And if the patient says, that's a long time to brush, acknowledge that, and don't have them not brush just because 2 minutes seems too long. I think there's a lot of evidence that caries control is about not how you manipulate the toothbrush, but what's on the brush. In fact, meticulous deplaquing of the teeth has not been shown to prevent caries. Only fluoride has. So we have to be careful what we emphasize. I just talked to a hygienist last week who has put guidance for patients online, and they use their phone to take a picture of the QR code, and then they can go home and call up this guidance. And so, boy, that's a slick technology. And I'm sure we're going to see more and more of that. But I want you to pay attention. And if you may use a self-management goal, a worksheet like this, you may have developed one that you're very proud of that's specific for your population or your clinic. And that's great. It's great to customize these things, but let's be really careful what we emphasize. Now, some clinic was proud enough of this self-management tool to post it on the internet. And so I saw it on the internet, and I really wasn't looking, I was just kind of curious as to what kind of things were posted. And I looked at the #1 goal. It said brush and floss twice a day. And I thought, really? We are asking people to floss twice a day? And worse yet, no mention at all of fluoride toothpaste. I'm a real believer that every time we put "and" in a recommendation, we make that behavior harder to follow. And if we mix up important, effective things with things that aren't effective, we are just making our situation worse. So let's have simple guidance to patients. Let's not ask them to change more than one behavior, 1 or 2 behaviors at a time. And let's make sure that the things we're asking them to do are things that are going to make a difference. And but finally, we come to sealants, the topic of the session, and this particular presentation of the levels of evidence makes a real strong case that sealants are highly effective if applied correctly. This comes from now 50 years of experience, where most of the experience has been with resin sealants, where how they're applied is really important to their effectiveness. Kind of just an overview. You all know what teeth look like, but I want to remind you that the teeth become vulnerable to caries as soon as they erupt. This tooth on the left has actually probably been coming into the mouth for several months now. It still have the operculum over it. It'd be really tough tooth to treat with a resin sealant because you just cannot stop the saliva from seeping underneath that surface. And so it's really quite common for us to wait until the tooth is in full occlusion before we try to seal the tooth. But that may mean that the next time we see the tooth, it looks like the one in the middle. What we're trying to do, obviously, is to get the tooth before it has caries, the sealant on it, like you see on the tooth on the right. Plenty of guidance for sealants. The guidance seems old now, but remember, the 2018 guidance reiterated something that had been discussed in a full-blown report in 2016 and earlier 2008 or 2008. Guidance on sealants. And I also want to call your attention to guidance that's focused on, the title talks about school-based programs, but it really is good guidance for people providing sealants in any situation. So what did those 2016 guidelines say? They made it really clear that putting sealants can prevent and arrest caries on both primary and permanent molars, to minimize the progression of non-cavitated lesions. Again, this is beyond sound teeth. They're recommending it. In fact, what changed between 2008 and 2016 was that they used this adjective, a strong recommendation. And that wasn't just a word that somebody tossed in. It's got a very specific meaning in clinical recommendations because it means that in most cases, the clinician should follow that guidance. They should only deviate in exceptional circumstances. There's no space between the recommendations, the ADA and the American Academy of Pediatric Dentistry. These guidelines were developed together jointly. And if you go to the AAPD website and look at what they say about sealants, this article from JADA is the one that they present as their continue to be their recommendations for the use of fit and fissure sealants. The guidelines go on to say that they can't recommend any particular merit of one type of material over the other, but they called on clinicians to reorient their efforts to increase the use of sealants. And why this reorientation? They had recommendations 2008. Why this need to keep recommending the clinicians to reorient their efforts? It's because they knew there was resistance. Even today, the most recent survey, the one reported in the now 2021 update of the Surgeon General's report, we still have barely crossed the 50% threshold for young kids, and we haven't reached the 50% threshold for 12 to 19-year-olds. And this statistic is only having at least one sealant. This isn't even talking about kids that have all their molars sealed. In 2001 survey confirmed that dentists were really concerned about inadvertently sealing over caries. Unless you think that 2001 was a long time ago and people don't believe that anymore, in that collaborative that Gary mentioned that I was really blessed to be a part of, I think it was the third or the fourth version of that collaborative. We had providers that came to this collaborative because they knew they wanted increased provision of sealants in their clinic. And even there, 28% of them acknowledged that they would not intentionally seal over decay. So there's still a lot of resistance to sealing over decay, in spite of the profession's recommendations to do that. We really should think about what would be the consequences of sealing over decay. This study really was the one that formed the basis for the 2008 recommendations to seal over decay. Since then, there's been more evidence. But they looked at effectiveness of sealants in managing non-cavitated lesions, and they found that it was very successful in preventing progression compared to not sealing the tooth. Again, since then, as they're recognizing this challenge people have, in this study, the teeth, these were teeth that they knew they had caries. I mean, they had, it was non-cavitated, but they had radiographs, showing that the demineralization on into dentin. They sealed these teeth with clear sealant so they could look at them. And so they monitored them over time by looking at them, by using diagonodent, by taking radiographs. And at the end of almost 4 years, sealants were 98% effective in preventing any progression to decay. I think it was like 4 out of 228 teeth actually progressed, and none of them progressed halfway, even halfway to the pulp in this period of time. So this is pretty convincing evidence that we can seal. These were known to be carious lesions, radiographically evident and clinically evident, and the sealant was successful in preventing any progress in almost all cases. We know that some dentists also think that they need to mechanically prepare the tooth, small fissurotomy to enhance retention of sealants. This was explicitly recommended against by AAPD in their 2016 restorative dentistry guidelines, because while it does increase retention, if the sealant is lost, the tooth is much more prone to caries. I checked their latest guidelines. They're silent on the issue, and I don't think it's because they changed their mind about this. I think they would have mentioned it if they did. I think they decided this was so clearly communicated the last time that they didn't need to keep repeating it. But I will note that the 2018 JADA recommendations on non-restorative interventions specifically said that enamel removal is unnecessary. And if you recognize the lead author of that, Rebecca Slayton, she's a pediatric dentist. I think you all know by now that we don't need to do a prophy before we seal teeth. In terms of if we're trying to enhance retention, a toothbrush prophy is just fine. But again, this gets back to the question I asked earlier: how do you prioritize treatment in your clinic? Do you provide a prophy at that first visit or at that recall visit, and with somehow convincing yourself that you need to do that in order to place a sealant? No, if the sealant's your priority treatment, you can use a toothbrush prophy to clean the tooth adequately enough for to place the sealants. Okay. So how about radiographs? I think it's important to realize that when the ADA recommendations talk about non-cavitated lesions, they're talking about lesions. I mean, it was very clear that they're talking about teeth that where decay can be seen radiographically. That mineral has been lost. It shows up in a radiograph. And the idea is that the integrity of the sealant is going to prevent the biofilm from being able to cause any more damage. But still, there will be dentists that look at a radiograph of a tooth with the sealant. They'll see radiographic evidence of decay under a sealant, and they'll say, this sealant is failing. I need to remove this sealant. It's failed. When in fact, the only way to determine that is if they had a before and after picture. They had a before picture that showed less decay than they see at the more recent one, then yes, there's decay is progressing. But it could very well be, I mean, there's no reason to think actually that radiolucency is going to change just because we've isolated that lesion from the biofilm. It's going to stay at that demineralized state indefinitely. But that doesn't mean that the sealant needs to be removed. So I think it's pretty clear that, well, at one time, maybe we said we're not going to, the tooth is low, if the tooth's at low risk or the child's at low risk, we won't seal. Now I think it's pretty clear we recommend sealing the kids that are low risk, kids are at high risk, and even where caries is active, we can seal those teeth. The criteria for sealing teeth should be the same for a dentist. There may be rules about who's allowed to make a diagnosis, but the criteria for how to assess a tooth to know whether sealants are appropriate are going to be the same for any clinician. And it should be following exactly the same rules. And this article from Fontana from 2010 provides a very nice discussion of that. Missouri is like many states in allowing hygienists to, in public health settings, to make the decision to seal a tooth in addition to placing the sealant. There's some states that still require a dentist to make the determination that a sealant should be placed, and some states that will allow hygienists in public health settings to make that decision, but not hygienists in a clinic setting, which just seems totally bizarre to me. I think the more appropriate protocol is for there to be an understanding of the hygienist and their collaborating dentist or supervising dentist as to which teeth we seal and which ones we don't. And if there's no question that this is a tooth that should be sealed, seal the tooth. And if there is a question, then ask the dentist for their opinion on that. Again, I think Missouri is a state that allows this. The question is whether that concept is embraced. And so I think we all need to work to embrace the idea that based on what we know about the implications of sealing teeth with decay are such that we want to seal those teeth. We don't want to say appoint the child to go to a dentist for a restoration or for a second opinion when that might lose our chance to seal the tooth and arrest the decay at that point. Now, what if a hygienist sealed a tooth that a dentist might have restored? Well, if that patient doesn't see a dentist for, say, 10 years, I can't answer your question. I don't know what would happen. I mean, maybe that would be bad. But for all others, I'm going to tell you that there's going to be plenty of opportunities to intercept caries progression in the rare likelihood that the sealant is not effective. And why do I say that? This study was done specifically to answer that question. The teeth were selected for this. They had all been treatment planned. There was 200 and some odd teeth. I think 30 some dentists in Denmark. These were all public health clinics in Denmark. A real world situation. This was not a situation where we're going to do stuff the dental school way and it's going to be a perfect restoration. We're going to compare a perfect restoration to a perfect sealant. This is real world situation. These were all teeth that were treated. They knew they had decay in dentin. These were all treatment planned for restorations. But they said, let's see what would happen if we sealed those teeth instead. So about a third of the teeth were restored. 2/3 of the teeth were sealed with resin sealants. And then they monitored them annually. And it turned out, and if the sealant had to be replaced, then they replaced it with a restoration. It turned out that the median survival time for the sealants that were not replaced was 7.3 years. They ended the study at 8 years. So who knows what the median time would have been if they'd extended the study. But it certainly shows that while that we can progress, we can stop the progression of even cavitated lesions. And if we have the opportunity for recall with any kind of periodicity, we ought to be able to intercept those where that sealed cavitated lesion is not working and go ahead and provide a fill-in. But that does get us to the question of avoiding restoration altogether versus postponing a restoration. And so you might say, well, if I'm more confident in the success of restoring a tooth, why would I postpone it? And I want to think about the system of care we're in. Who is available to provide the service and where? Restorations that require drilling and filling, only a dentist can do that. And they typically do that in a clinical setting, or even if it's a mobile, fairly elaborate mobile setups. But a hygienist can place sealants in other locations, perhaps places where the patient doesn't face barriers to care. And we also need to ask the question, who else needs a service? While that dentist is restoring a tooth that could be sealed, is there another patient that really does need a dentist? That really does need a dentist to place a filling in there. And in almost all the cases, the answer is yes. There's other patients that definitely need services that only a dentist can provide. So let's use our workforce effectively to seal teeth, even if rather than completely avoiding. That study kind of shows us that 70% of the time we are gonna completely avoid the need for restoration, but maybe 30% of the time all we've done is postpone the need for restoration. But that's still, I think, a net positive for your community. Looking at the clock here, yeah, we're about on pace here. So I want to turn to that question about what's better, glass ionomer or resin? Is one better than the other? The guideline panel suggested that dentists should take in to account the likelihood of experiencing a lack of retention. Remember, we showed, this is the same picture I showed earlier of this erupting tooth with operculum. There's no question, but the resin is retained better under ideal circumstances. But I think those of you that have tried to seal a tooth or have seen teeth that had been sealed in this situation probably can tell me the horror stories about how the sealant never really was retained on the distal fossa of the occlusal surface, and it actually became a trap that encouraged decay rather than discouraged decay. So for teeth like this, they're not fully erupted and where moisture control isn't going to be ideal. Glass ionomer or resin modified glass ionomer is going to be preferable to resin sealants. And that means to me, that tells me that every clinic should be able to use glass ionomers for those situations, have the capability of doing that. But I wonder if we're even asking the right question. So the assumption is that when a sealant is retained, it provides complete caries protection. And it probably does. But if for caries protection is what we're interested in, not retention, then just because a sealant's lost doesn't mean caries hasn't been prevented. And in fact, there is some evidence that in terms of caries prevention, glass ionomer and resin-based sealants are basically equivalent. I don't think we're going to ever answer this question completely. Both types of sealants are so effective, you would have to mount such a large study over such a long period of time to see a difference. No, it's not in the best interest of any company, either making glass ionomer sealants or resin sealants. It's not in their interest to do that study. So I think what mainly we need to think about, what do we know about these, and what do we know about the situation in our clinic, and what do we know about our opportunities to use these materials, and go forward on that rather than waiting for somebody to explicitly tell us whether one is better than the other. So again, most studies show clearly that retention is better for resin, but in terms of caries reduction, it's not clear.
So we have a question. Well, someone was asking about a link. We didn't pick that up earlier, but will you make the slides available later?
Yeah, I think we can do that in a PDF version, and then you'll be able to. I think really all of these. Well, I don't know that all of the complete papers will be available, in open access, but at least the abstract can be available in headline. So yeah.
And I think I understand this. Is it absolutely practical and appropriate to place multiple? No, it is absolutely practical and appropriate to place multiple sealants on several teeth in any quadrant, regardless of mixed or permanent dentition. Why is this not a declared standard? The ATSDD and ADA have endorsed this concept for 6 years now. Why is it not promoted as a condition for participation in school sealant programs? And why wasn't this done before? So that's a lot.
There's no question, but the most caries-prone teeth are first and second permanent molars. So that has been the emphasis. If you're the dental plan, Medicaid or otherwise, and you're paying per tooth, which we have this fee-for-service thing, then you have to say, well, okay, I know that first and second molars are very caries-prone. It's cost-effective for us to seal these teeth. We'll do that. And so I said, well, I want to see, well, how about the bicuspids, permanent bicuspids, or how about the primary teeth? Well, the decay rate's lower, so the return on that investment is going to be less. And so these plans say, it's not worth it to us to, we don't get a good return on that. If we pay people to place these sealants on all those teeth, we're not going to get our money back on that. We're going to lose money. Now, I certainly agree with the concept. And in fact, we'll talk more about glass ionomers in a minute. And if you're really trying to control caries, you would put glass ionomer on the occlusal surfaces of every single tooth. And I think we will evolve to the point where dental plans, programs are going to say, we'll pay you to keep kids caries free or cavity free. And you use whatever technique allows you to do that. And instead of making a payment per tooth, they you provide the care that you need and you get paid a certain amount. I was participating in a listserv discussion about California. Apparently silver diamine fluoride has been added recently. And they make the clinician take a picture of the tooth to show that there was a lesion that needed SDF, as I understand the discussion. And so I asked one of my colleagues in a community health center in California, like, what's that all about? And she said that she had been on the Medicaid advisory committee a couple of years ago, and the dentists were insisting on getting paid for each tooth that they put silver diamine fluoride on. Well, any of you that have used silver diamine fluoride, so you have this whole challenge of getting the patient into the clinic, doing the survey to find out if they, if they or anybody in their families had COVID, taking their temperature when they come into the clinic, gowning up, setting up the room, breaking out the little vial of ampule of silver diamine fluoride. Once you break open the ampule, you've got it. Whether you do one tooth or 10 teeth, the per tooth cost, the marginal cost of putting SDF on one more tooth is virtually nothing compared to the total cost. I don't understand why dentists would insist on being paid for each tooth, but they do there, or did. And so then you have the dental plan setting up all these barriers for using it. They're not saying to a dentist, you can't use it on every tooth. They're saying, we're not going to pay you. And I'd say the same for somebody wanting to seal all the teeth. You can seal every occlusal surface of every tooth. In fact, it's my understanding that in the Indian Health Service, that's how they've made really marked improvements in reducing early childhood caries, is they put glass ionomer sealants on every tooth. They just don't get paid for it. They don't get it paid for on a fee-for-service. Okay.
I think that's a very good answer. There was a further comment that I think falls in line with what you're talking about there. And I'll just, it's your presentation. I'll just make a comment as a non-dental professional. I think generally people gravitate towards what they know and what they're used to. And the entire dental world is structured around fees for very specific activities. And to move on from that to pay for performance or outcomes, or even something in between where we are now, some other alternative payment method, it's a pretty big leap for everybody involved. It isn't just the payers, it's all the clinicians and their staff and the way they organize their business and that. So it's a significant barrier, and I think you just have to recognize that.
Yeah, no question about that. I don't know, there's this concept of tipping point. I don't know how out of whack our system needs to be in terms of how we pay for things versus what the science tells us we should do. How far out of whack before you reach the tipping point? I'm confident it's going to happen. I mean, it just makes too much sense to not happen. But whether that's in 5 years or 10 years or 20 years, and whether it's very disruptive when it happens, I don't know. So, in all likelihood, it's going to be, we're going to work this out in small studies. There'll be small groups, dental plans where, there may be several group practices, agree to receive reimbursement, on a different basis, and the purchasers of the care, agree to that. Say, follow these guidelines, and we'll pay you a certain amount of money. The thing is, with most of these programs, we have experience. We know what it costs to provide the old traditional care. How many fillings are going to be done each year and things like that. So I think these things can be modeled, and I want to be optimistic that eventually they will. I did want to talk more about why we might still feel comfortable with using glass ionomer sealants. I mean, how could it be the glass ionomer sealants fall off? I mean, they're not retained as well as resin sealants, and yet there doesn't seem to be a difference in their ability to control caries. So we really need to think about those emerging molars. They're highly susceptible. When they erupt, the surface isn't fully mature. It can take from 6 months to 2-3 years before there's full occlusal contact. Once the teeth are in occlusion, just eating food kind of, scrapes the plaque off the tooth surfaces. But until then, we may, have, again, 6 to 12 to 24 months where plaque's just building up and it hardly ever is removed, especially because 6 and 7-year-olds don't necessarily have strong toothbrushing habits. If we can delay decay for 3 years, well, what's changed? Well, we have a more highly mineralized enamel. We've had more opportunity for daily exposure, whether that's in the tap water or the toothpaste, that's allowed that surface hydroxyapatite to convert to fluorapatite. And the kid's that much older, and maybe they're more reliable or they're more skilled toothbrushers. So the tooth is much less susceptible 3 years later, and that could very well be why that if the sealant is placed early and then lost, we don't see a difference in caries progression. But it's also related to the properties of glass ionomer compared to resin. Glass ionomer is porous at a microscopic level. And so it allows the enamel to continue to mineralize even under the glass ionomer. Moreover, there's fluoride in the glass ionomer. So that fluoride actually can be incorporated into the dentin, or if it's in a cavitated lesion into the, on enamel, and if it's a cavitated lesion, even into the dentin. And then I think I have a picture of it here. No, okay, I don't. At some point in time here, I'll show you a picture. The glass ionomer material may be retained deep in the fissures. So even if it's completely worn away, visually to what we see, the glass ionomer may still be at the deepest parts of the fissures, again, keeping the biofilm away from the tooth. So conclusion is that both glass ionomer and resin sealants are significant for caries prevention. Which you use should be related to what's the clinical application for them. And what many of you, or perhaps all of you, have experienced is in the last 2 years is use of glass ionomer may be the treatment of choice if you're in a situation where you do not want to generate aerosols, both for the good of the patient, the good of the providers, and the good of the community. This was the guidance from CDC at the beginning of the COVID era. Remember when practices were closed down and then slowly they reopened, and they said prioritize the most critical dental services and provide the care in a way that minimizes harm to the patients and harm to the personnel. Faced with that, are sealants a high priority? Are they the services we should be prioritizing? I would say yes, knowing how caries prone those teeth are when they're erupting, but we need to do it in a way that that minimizes harm to the staff, and certainly resin sealants that require totally dry field and the use of the air water syringe they can't help but blow the saliva and with it the COVID virus around. So yeah, I think sealants are a high priority, but the way to provide it in this COVID era is with a technique that doesn't require generation of aerosols. So I'm going to talk a little bit about glass ionomer sealants, and some of my slides I want to give credit to Michelle Wright, who's a representative from GC America. That's why you see the product, their sealant product here, Fuji Triage, and Irene Hilton from NOAA and I and Michelle made a presentation about this based on the same material in July of 2020. When practices were just starting getting open, and some of you may have actually seen that and begun to use glass ionomer at that time. I don't know what glass ionomer cement is. I mean, I can tell you what the words say. I don't understand the chemistry. So it's these kinds of glass, and then there's this powder, and there's this liquid, and the liquid is very specifically a polyacrylic acid, but a water soluble. So this is not a resin that is hydrophobic, that water and it never mix. This is an acid that actually is water soluble. And that has a lot of implications for our ability to use glass ionomer on moist tooth surfaces. So it's a self-curing material with an acid-base reaction, and it contains fluoride that's released over relatively long periods of time. Really important to understand. There's a conditioner used for it. It's a clear liquid. It might seem like the same stuff we do for acid etching resin sealants. Totally different chemistry, totally different purpose. Polyacrylic acid is being used to remove the smear ladder, the microcrystalline debris, the organic debris. Just remove the debris from the surface of the tooth so that the hard tissue is exposed. Phosphoric acid, the purpose of it is to dissolve away the mineral. You want to leave dissolved mineral, leaving the collagen skeleton of the surface of the tooth so that little tags of resin can go in those holes. And so it's a micro retention, or I'm sorry, it's a mechanical retention. Resin sealants are mechanically retained. Glass ionomer sealants are not mechanically, chemically retained. Here's a photo electron scanning micrograph. Here's the enamel. This is the glass ionomer, and you have this chemically fused area. There aren't little tags of resin penetrating into tubules. This is different chemistry. This is a chemical bond. In fact, I've seen a demonstration where if you take a large filling on a tooth and you start smashing it with a hammer, you'll break the glass ionomer for sure, but you don't break this bond. This bond is actually stronger than the glass ionomer itself. So but again, it's very different than the mechanical retention of a resin sealant. So you have these benefits that you don't want to work underwater, but it's moisture tolerant. You can work in at least a moist field. You have to put a conditioner on the tooth, or you don't have to, but it's good to remove that debris. But it's for a shorter period of time. And again, it's not etching. It doesn't have to be, we don't have to keep the saliva away for the entire time between etching and placing the resin sealant. It's self-cure, longer period of time. I know you can, use a glass, use a light, curing light, and sealants can set up really fast. So this is going to be a slower to a cure than a resin sealant, but that's not going to affect the effectiveness. Glass ionomer releases way more fluoride than any other sealants, way more than resin sealants. And that fluoride is recharged. I don't quite understand how that works, but there's fluoride in the toothpaste and fluoride varnish and even fluoride in the drinking water. And so the porous glass ionomer material can actually recharge and continue to make fluoride available to nearby tooth surfaces. Chemically bonds, not mechanically, and it can keep the bacteria out. This particular product, Fuji Triage, is a low viscosity. Actually, high viscosity ones work as well, but this is a low viscosity one. It will wear into occlusion, so you don't need to use worry about high occlusion. It's a soft enough material that'll wear away. And to the point earlier about sealing all vulnerable teeth, you can seal all 4 erupted molars. I'm again assuming that the 4 first molars come in, and you got to wait 6 years before the next molars come in. But you can basically seal a lot of teeth in a short period of time using glass ionomer sealants. And again, one of the real advantages is that glass ionomer encourages remineralization, whereas a resin sealant actually prevents the exchange of minerals that would allow a tooth to remineralize under the sealant. Glass ionomer can be replaced under moist conditions. Let's say you use glass ionomer, let's say you decide to use this for cavity. A large resin filling is going to shrink, whereas glass ionomer doesn't shrink, and so you're going to less potential for shrinkage, which would often lead to micro leakage. Again, this is just this particular product claiming that it releases much more fluoride than other glass ionomer products. But I think the main thing to show is the difference between, now this real line you can hardly see. You can buy resin sealants that say they release fluoride, but see how much fluoride they release. And you'll see that it's much less than, they're saying it releases fluoride because they realize this is important, but it's not nearly as much as glass ionomer. This is a photomicrograph I mentioned earlier. Yeah, sure, this is perfect. This is the company says this is what a sealant can look like. Glass ionomer sealant can look like 3 years later. I'm sure it can. We're more worried about the situations where it's all worn off and only leaving a little bit in the pits and fissures. And I think that this is, again, why we don't have to feel if you want to, if you're mixing up a batch of glass ionomer and you want to put it on that tooth, sure, go ahead and do that, but you don't have to, because in all likelihood, there's a tag of glass ionomer that's still protecting that tooth. I just wanted to, with our remaining time, show you how this can be done without generating aerosols. Those of you that work with school programs, think about this as a technique that can be used in school programs without having to set up suction and an air compressor for the air water spray. Or think about it just in a clinic where you're trying to eliminate use of aerosols. Obviously, the first thing you do is you pick the tooth you want to seal. You clean the ideally you would use pumice with a rotating brush, or you'd use pumice to clean the chewing surface, but then you'd have to spray the pumice off and use suction to keep it out. That's great. But if you didn't do that, you could just use a cotton roll to wipe the plaque off the tooth. The conditioner, again, it's not acid etch, it's polyacrylic acid. It only has to be on for 10 seconds, which is shorter than the time it takes for acid etching. And then the recommendation here, again, in a non-aerosol generating way, to take a wet cotton roll and press that into the tooth to kind of flush out any of the debris that's been suspended by the polyacrylic acid. The product comes in a little capsule. You tap it to loosen up the powder, you put it in the triturator, you set it for a certain amount of time, and people with experience this realize if they need more setting time, like they want to do 4 teeth instead of 1 tooth, or 4 teeth instead of 2 teeth, or whatever, they can change the setting time by how long they set the triturator for. It's putting a little applier squeezed onto the tooth, and here's the part that may, if you haven't done it before, may be surprising. You use your finger to press the glass ionomer into the pits and fissures. This technique can be used for, and it has been used for now 25 years, for both high viscosity and low viscosity glass ionomer material, it's called the press finger technique. And you simultaneously press the glass ionomer material into the pits and fissures and wipe it off of the cusp inclines where you don't want to leave a high occlusion. Leave it for 1 or 2 minutes. Again, 1 or 2 minutes is longer than a resin sealant. You can get a resin sealant to set up right away, but remember, this sealant is not an occlusion, and if it is, it's going to wear away. If we can just let it sit there for a couple of minutes as the patient's cleaned up for discharge, we're going to have a good sealant as they leave. 2 points to make.
Sorry, just to interrupt. There's another question. There is a self-adhesive flowable resin by Shofu Fit SA. Do you recommend this as a sealant?
I don't know enough about individual products to make a recommendation, but I can imagine companies are trying to figure out hybrid kind of solutions. I don't know enough about that. I know that there's a basic glass ionomer product that works. I just don't want to speak to that. Maybe others that can. I think the main thing is when you switch, if some practices may still use both, some practices may switch completely. Just make sure that you understand the difference. You don't ever want to acid etch a tooth you're going to use glass ionomer on. The glass ionomer wants to bond to mineral tissue. You don't want to dissolve mineral tissue. You want it to bond to mineral tissue. Whereas acid etching, you're trying to removing minerals so you can have those collagen framework, then leaving little mechanical tags of resin there. And also it'll over dry the tooth. Believe it or not, teeth have moisture in them. They have water in them. And you don't want it, that's part of what's needed for the reaction is the water that's inside the tooth, including, and also then the water in the polyacrylic acid, which is the liquid in the, not only the conditioning, but it's also the liquid that's in that little capsule. So don't acid etch, don't over dry the teeth. And remaining time, if you're a member of NOAA, and perhaps even if you're not a member of NOAA, NOAA has webinars that have been done about how to increase sealant performance. There's 10 steps for increasing sealant performance. The number one recommendation is what's called same-day sealants. Make this a priority. Seal the tooth while the kid's in the chair, or that first appointment, that recall appointment. Don't reappoint them for appointment that they have a good chance of breaking. Don't miss your chance. Prevent decay when you can. And and then if you try to do same-day sealants, and you're having trouble because of the amount of time you have set aside, kind of break down the steps. I mentioned earlier, don't have the dentist come and check the hygienist. If the dentist and hygienist are in complete agreement on which teeth should be sealed, the only time you would want to wait for the busy dentist to come from another operatory to check would be those few situations where there's some question about it. And in those cases, for sure, get the dentist's opinion. But when you know the dentist has got the same view as the hygienist, why would you waste any time during that appointment? They talk about working backwards, making sure that we have consent of the parent right at the front desk. They look at the chart and they think they recognize that this child may get a seal, and they talk to the parent right then. So we're not taking time from out of that half-hour appointment or whatever to have to get the consent. So again, NOAA has good guidance on their website for how to do this. We're kind of running out of time here. Let me just quickly say that I want to be open to the fact that we're going to get new information over time, and we may have other approaches to this. I'm going to share briefly. Program was written up in JADA 2008, program done in Boston. Saw kids twice a year, fluoride varnish and glass ionomer sealants, including what they called therapeutic sealants. If there was a cavity, they still smeared glass ionomer into it. And they had they figured out what it cost. They had good success over time. They exceeded the healthy people goal of how much to lower the untreated caries rate. They have a new protocol in place that they're testing. Instead of using glass ionomer, they're using silver diamine fluoride. If you remember the timer, it takes less than half as much time. It costs less. Early pilots show that it's not as effective. And so you might say, well, that doesn't seem like something we would want to do compared to the first protocol, which was so effective. But remember, they did it in less than half the amount of time and in less than half the cost. And those of you in school programs know, I think we're really aware now of how concerned people are about disrupting school. And so anything that we can do that minimizes that disruption, has the kid go away from class less, is going to be something that's valuable to teachers and administrators. And in New Hampshire, where they are testing this, the teachers even noticed that the kids were coming. But you think, well, the teacher doesn't mind that the kid's gone for a half hour. No, the teachers noticed the kids were coming back into class faster, and they asked about that. So unfortunately, these trials, both in New Hampshire and in the Bronx, were started just as the year before COVID hit. That was the first school year. And I don't know that they're going to actually learn anything, because there's been so much disruption. I think the research money that was made available, unfortunately, may not be, research funders are fickle, and they may not allow them more money to continue this project long enough to learn anything from it. But if they don't, back to our earlier point about, change occurs slowly. If this study isn't supported, some other study will be supported. So let's be open to constantly changing our protocols based on science. That's going to lead for the best results for our community. So I'm going to leave this slide up while we ask some questions, Gary.
I think we have managed to cover all the questions as we went along, although I would encourage people, if you have additional questions, go ahead and pop them into the chat.
I'm available to stay longer if others are. I mean, if you don't have a limit on this, I'm available as long as we need to, actually.
Yeah. Well, we can certainly stay on and leave the webinar open if you have other questions. I will, while you're thinking about that, I will note that Ann Hoffman put a comment in there about changing the mindset of many dentists to seal molars with non-cavitated lesions and to seal more teeth overall will take time. Keep presenting the information and data to support sealants to be used as a preventive tool along with proper oral care and fluoride varnish application. So very, very good comment there. And I want to say again, thank you to the Office of Dental Health of the Missouri Department of Health and Senior Services for sponsoring this, and thank you to the Missouri Primary Care Association and Karen Dent for work with the CEs. Speaking of which, I have put a a code into chat for the CE survey, and you should have already gotten an email with that, but I've also put the link for the survey. The code is MCOH1, the number 1, and I put it in the chat again. Any other questions or comments that we have? Well, I want to thank you, Dr. Moss, for really an excellent presentation. I think it was very engaging. We could certainly tell that people were paying attention, even through the fog of webinar technology. And it's great information. I learned a lot. You kind of made me want to go back and start over and become a dentist, but probably it's too late for me. But maybe others are inspired. I think these system changes that we got into a little bit with sort of people, overall changing perspective and the way things are done, I think that does take time. I think the question, Dr. Moss, about what's the critical mass for that, I don't think anyone knows that. I think it's something we just have to, as Ann commented, I think we just have to keep at it and keep sharing the science, and some people will adopt and others will be slower to do that. I mean, we know that.
I'm glad, I looked at the list and saw kind of a mix of dentists and hygienists. I don't know that, the locations necessarily. I noticed a couple of people from academia that, I think it's really important to view these as a system, in your community. And have the dentists and the hygienists kind of on board and say, these are our resources. This is what we can do. This is where the people are with the need. Again, a lot of barriers to school programs now, but hopefully it won't always be like that. And it requires being thoughtful about what are we giving up. If we're concerned about if we have this notion of what perfect ideal care is, what are we giving up? How many people are not getting any care at all while we continue to do that? And if we do make it relatively easy for people to get their recall visits with either a dentist or a dental hygienist, those few people that actually need to be elevated to a higher level of care, we're going to find those and get that whatever that other treatment is, a restorative treatment. But if we don't have a system that's efficient like that, there can be a lot more that don't ever get that effective preventive service. We're going to, ultimately have many more that reach that symptom, right? We looked early at what's the difference between a sign and a symptom. Well, a sign is something we can see, but a symptom is definitely something the patient sees. And actually, we want to we want to intervene before there's a symptom, if possible. We want to do it when only our trained eyes can see the problem, and not that the patient's in so much pain that they find them motivated to come in. So yeah, I really encourage a team approach, and and within your state, the more people that are trying to practice that way, and can defend each other. I think one other thing I was going to mention about Missouri, the standard of care in Missouri legally is follow the Daubert rule. And that basically says that to defend what a clinician does, they rely on evidence, not the kind of the old school thing where, well, you get some expert and they say, this is what I've done for many years with my cases and everything. There's still some states that follow that. That's, if there's a lawsuit, they bring in the expert to do that. But Missouri is a state that follows the Daubert rule, which basically says, what does the evidence say? What does the scientific evidence say? And as long as you're following that, then you're protected from any liability. So, but, and back to our earlier point, that doesn't mean people aren't going to criticize you. Being protected legally, knowing you're doing the right thing legally, doesn't protect you from criticism. So that's where we have to kind of be willing to stand up for one another and say, we support people that follow evidence-based care. And we know the difference between a cavitated lesion and a non-cavitated lesion, and if the science says that we can seal non-cavitated lesions, we're going to do that. And we're also going to realize that if every once in a while we seal a cavitated lesion, that's probably going to be good for the patient too. And we're not going to consider that bad dental care. Bad dental care is watching, waiting, and then the cavities happen.
All right. Well, thank you all very much. And again, Dr. Moss, thank you for doing this excellent presentation. And we will get a recording of this out. You've gotten a lot of thank yous in the chat as well. And so
that.
I think we will. I think we'll leave it there. Dr. Moss, if you have any follow-up questions for me or anything, just let me know, and we'll get together. And so with that, I'm going to say thank you to everyone, and we're going to call this the end of the webinar. Have a great day.